Good evening, everybody. I'm Dr. Sanket Shah from Hypercoagulable Cancer and Research Institute. And welcome to the master class in hematology. This will be the fourth lecture. And I think last minute, Dr. Sachin Jadhav, he has some important work to do. So the topic, hypercoagulable state and its approach, will be taken by none other than Dr. Sanket Shah himself. By this time, you all know Dr. Sanket Shah is a senior medical oncologist, hematologist, and bone marrow transplant physician. And he's trained at GCRI and then at Tata Medical Center with Dr. Mehman Chandi for 2 years in bone marrow transplant. And now, right now, he's practicing in Ahmedabad as a hemato-oncologist and bone marrow transplant physician. So he will be talking on hypercoagulable state and its approach. Over to you, Dr. Sanket. Not audible.
Yeah, good evening, sir. Good evening, everyone. Thank you for kind intro, sir. I'll share my screen. Okay. Okay. So today's topic of approach to hypercoagulable state. Before I start, I'll genuinely say I am not an expert of the topic, but we have experts from our group. This is our group at HOC Vedanta, and they are here during these panel discussions and all that at the end of session to take our various questions and cases and to guide us through that, right? So to start with this chart, which we are all knowing from our first MBBS, probably I have gone through Sambulingam, you all must have gone through the same also. So the first portion, intrinsic pathway, there is an extrinsic pathway. Now they both pathway converge here for reaching the common pathway, which leads to the cross-linked fibrin clot formation, thrombus formation. There are also certain inhibitory factors like activated protein C, antithrombin, plasminogen factor, all that factor that keep the checking. So this system is beautifully working in our body, which in normal circumstances keep the blood in the liquid form, but when there is some pathology happens, it results in the formation of thrombus or clot. When we are talking about thrombus formation, there is always we have to understand the Virchow's triad. The first is vessel wall abnormality. There is the venous stasis or the blood stasis, and last is the hypercoagulability, which we are going to talk today. So hypercoagulability can be defined as a tendency to have thrombosis. It can be due to inherited molecular defects or as a result of certain acquired conditions. It can be asymptomatic or it can be devastating and even lethal. Sometimes we are also using thrombophilia instead of hypercoagulability. Thrombophilia is also the abnormality of blood coagulation that increases the risk of thrombosis, but there is some difference between hypercoagulable state and thrombophilia. So thrombophilia is basically subtype of the hypercoagulable state, and classically it is all the inherited conditions plus antiphospholipid syndrome. So we can say that all thrombophilias are hypercoagulable, but not all hypercoagulable states are thrombophilias, right? So acquired and hereditary hypercoagulable states, which are the acquired factors? Major surgery, trauma, immobilization due to any reason, malignancies, pregnancy, OC pills, HRT, antiphospholipid syndrome, heparin-induced thrombocytopenia, paroxysmal nocturnal hemoglobinuria, obesity, nephrotic, and smoking. While here there are the hereditary factors, which are the genetic factors. Remaining major thrombophilias, they can be inherited or acquired. There is only single acquired thrombophilia, which is APS, and remaining all are inherited. It can be due to natural anticoagulant deficiency or gain of function mutation. So we will discuss one by one each condition briefly, and their laboratory testing, which will be followed by a generalized approach for all the patients. So first, inherited thrombophilia increase in procoagulation activity. So factor V laden mutation, we all know, we are commonly using this terminology. It is also known as activated protein C resistance. It is most common inherited thrombophilia. There is a point mutation in the factor V gene, which results or prevents its natural breakdown from activated protein C. So here, if you can see this activated protein C, it causes breakdown of this activated factor V. Now, when there is a resistance to this site, there is persistent activated factor V is there, which converts the prothrombin into the thrombin, resulting in a thrombus formation. Right? Now, prevalence. A 5% prevalence in the white. However, the most important thing, virtually 0% in Asian population, right? So probably in Indian patients, we probably don't need to go for the factor V laden mutation testing at all. However, to continue our theoretical knowledge, 20% of the patients of TVT have factor V laden mutation. There is 2 to 3-fold increased risk of VT in heterozygous, but in homozygous, the risk increases up to 80 folds. Risk of arterial thrombosis is absent unless there is second risk factors like smoking or atherosclerosis. Pulmonary embolism is also minimal and does not increase risk of VT recurrence, right? Recurrence rate is almost nil. So when lab testing, so first we have to do activated protein C resistant functional assay. Here what we do, we first do the APTT of the patient and then we add exogenous activated protein C. This actually leads to the prolongation of APTT. In normal patient, it doubles the APTT, but in patient with APC resistant, it does not have any effect on the APTT, and that will determine the APC resistant test. However, there are certain cases which can lead to false positive testing like elevated factor VIII level or very low protein S. Causes of prolonged baseline APTT itself can even lead to the APC resistant functional assay. There are certain second generation assays are now available to rule out all these problems. The other lab test which is available is identification of factor V laden mutation directly by the PCR method. We can even do direct testing of the factor V laden mutation, but that is not cost-effective way, and it cannot detect mostly acquired APC resistance. So what is acquired APC resistance? Here factor V is normal, still the APC is resistant, you can see. So there may be autoantibodies that keep the factor V activated. There may be untreated hematological malignancies, lupus, pregnancy, OCPs. Active thrombosis at present can also lead to APC resistance and elevated factor VIII already mentioned. The next is prothrombin gene mutation 20210A. Now this mutation is a gain of function point mutation resulting in increased prothrombin activity and level. Again, the prevalence is 1 to 3% in general population and 5 to 10% in patients with venous thromboembolism, but it is rare in Africans and Asians. So in Indian, it is also again rare mutation. It can be detected through DNA analysis. At this time, it is a very mild risk factor is considered and not associated with arterial thrombosis, and the relative risk is only 2 to 3 times the normal population. The third is elevated factor VIII level. Factor VIII can be elevated during acute phase reaction, elevated estrogen levels, pregnancy, or even after aerobic exercise. But this is usually transient and gradually it comes to the normal. However, when the level is more than 150% of the normal, is an independent risk factor for thrombophilia. Its prevalence is considered to be the 20 to 25% among the patients with the VT. Factor VIII activity assay level is available. If you found the factor VIII activity is low or high, then you have to do the antigen quantitation assay to confirm the result. Factor VIII measurement should be postponed until at least 6 months after an acute thrombotic event, 6 weeks after giving birth, and should be repeated after 3 to 6 months if there is persistent elevation. Now, important inherited thrombophilia due to decreased anticoagulation activity. Amongst these, the most commonly we do protein C and protein S. They are transmitted autosomal dominant way. The prevalence is around 0.1 to 0.5% in general population, while 1 to 3% in patient with VT. 70 to 75% of the affected individuals develop one or more unprovoked events in their ages of 10 to 50 years. Both DVT and PE are common, but arterial events are rare. Homozygotes are very rare and can present with the neonatal purpura fulminans or DIC in very early life. The deficiency can be either only in the activity or decrease in the absolute level as well as activity. Right? So lab testing again in the same way. First, you do the functional assay to determine how much is the activity. If the activity percentage is lower than the considered normal, then it should be supplemented by immunological assay to see whether the quantity is also low or normal, but it is just the functional deformity. If it normals activity at the functional assay, you don't need to do any other assay because it rules out the deficiency. However, there might be false increase in the level when you are already on anticoagulant therapy, or in case of lupus anticoagulant or factor V laden mutation. And false decreased activity level can be seen in elevated factor VIII levels. Apart from that, acquired deficiencies can also be seen, which is much more common in case of liver dysfunction or vitamin K deficiency, because both the factors are vitamin K dependent. Active thrombosis, DIC, nephrotic syndrome, L-aspergillus treatment, all this protein losing to neonates or even immediate post-op period result in protein C or S deficiency. Decrease in protein S, apart from this, also seen in case of OC pills, second trimester, third trimester of pregnancy, and acute reaction. For protein C, pregnancy and OC pills actually cause increase in the protein C level, while protein S is decreased in this condition. Any abnormal assay should be repeated after any such condition is resolved to confirm the test results. Next is antithrombin 3 deficiency. Again, autosomal dominant, prevalence is around 0.1%. It probably carries the highest risk of thrombosis among all hereditary thrombophilias. Again, it is venous and not the arterial. Abnormal vessels like mesenteric vessel, cerebral vessel, portal vessel can be affected in such deficiencies. Thrombosis occurs early in the life, and most of the cases it happens before the age of 35 years. Homozygote stress is almost universally fatal in utero. Again, deficiency can be quantitative or it can be qualitative. The important clinical clue is difficulty in achieving therapeutic APTT while receiving heparin. So heparin basically needs the antithrombin to act on the thrombin and prolong the APTT. In case of antithrombin deficiency, APTT will not increase despite whatever the dose you give of conventional heparin. Lab tests are available again for the same way for functional assay, and if it is abnormal, you check with the antigenic quantitative assay. False low level of antithrombin, acute thrombosis, heparin treatment, well, it is utilized by heparin, other systemic disease, a nephrotic syndrome. And those who are on warfarin treatment, the level is elevated or it comes to the normal. So if you are on warfarin, testing the result and result comes to the normal, still you have to recheck after stopping the warfarin. Next is this fibrinolysis, which is not much common, but most of the time it is similar to the protein C or S deficiency. It includes either plasminogen deficiency or deficiency of plasminogen activator, or there is an activator inhibitor. All condition ultimately leads to the decreased production of the plasmin and thereby prevent the fibrinolysis, and the clot remains there or increases in activity. The fourth one is congenital dysfibrinogenemia. Here fibrinogen itself is abnormal. However, bleeding here is much more common rather than the thrombosis, which is seen only in 20% of the patients. And the last is factor 12 deficiency. Isolated prolonged APTT in a patient who is presenting with a thrombosis, but it can be corrected with the normal plasma, is a indication for factor 12 deficiency, right? So thrombosis, prolonged APTT, but getting corrected with normal plasma. Other inherited thrombophilia, one which I want to discuss because we are commonly taking it as a cause for thrombosis, is hyperhomocysteinemia. For almost all the patients, we do homocysteine level, it comes out slightly elevated, and we consider it is hyperhomocysteinemia causing the thrombosis. So moderate is 15 to 30, intermediate is 30 to 100, and severe is then value is more than 100. So homocysteine is basically produced during the methionine cycle, and it requires the various enzymes as well as the various vitamins for its conversion into the methionine. So any deficiency of any of that can result in the homocysteinemia, hyperhomocysteinemia. So acquired causes include vitamin deficiencies, renal failure, thyroid failure, rheumatoid arthritis, and certain drugs can also cause the acquired hyperhomocysteinemia like methotrexate, cyclosporin, or phenytoin. Now, hereditary hyperhomocysteinemia is caused by the defect in the any enzymes which are involved in the metabolism, and most common is the MTHFR polymorphism, right? It is very common, frequently seen around 10 to 40% of the general population who are heterozygous for this mutation. However, homozygosity is seen in less than 10% of that. Elevated levels of homocysteine are known to be a risk factor for arterial thrombosis, venous thrombosis, and fetal wastage. The relative risk is 2.6 times in a moderate to severely high level. This is important. Just by 15 or 16 or 17 doesn't make it very high risk. Should be at a higher level like 20, 30, 40, 50. Then we should try to attribute it with the homocysteine. The exact mechanism is not known, but it's supposed to be combination of like increased procoagulant indirectly, or there's decrease in the anticoagulant's activity, or it might cause the endothelial dysfunction resulting in the thrombosis formation. Measurement of the homocysteine level is commonly used, but there is lack of standardization between different labs. And most important, acute thrombosis actually cause increase in the homocysteine level. So testing at that time will not be the adequate or appropriate. Again, mutation can be tested by PCR method, but its clinical significance has not been documented at any point of time. And most importantly, using homocheck that we are using commonly for reduction of homocysteine level in all the patients has not been shown to reduce thrombotic complications, right? Now, other rare inherited thrombophilias, we can skip this. Regarding acquired thrombophilias, the most important of all acquired thrombophilias is antiphospholipid antibody syndrome. It is probably the most common hypercoagulable disorder. Antibodies that are bind to plasma protein that have an affinity for phospholipid surfaces. And these antigens might be beta-glucoprotein, prothrombin, or various factors in the coagulation cascade. It can be primary, which is much more common, or can be secondary, as we can see along with the collagen vascular disease like SLE, like infections, as we have seen in the COVID also, and certain medications, phenytoin, hydrochloride, phenothiazines, cocaine, quinine, and certain sulfur drugs. It's associated with increased risk of both venous and arterial thrombosis, around 2 to 11-fold increase in the initial VTE. More the antibody titer, higher the risk. Increased risk of recurrence, also there, 12% at 1 year, reaching up to 30 to 45% at 10 years. It plays an important role in risk of maternal complication. It is termed as obstetric APS, which is seen around 6% of the women with recurrent pregnancy losses. Rarely, there might be acute thrombosis in multiple vascular beds simultaneously, which is termed as a catastrophic Epla syndrome, which is very fatal. What is the clinical clue? You have elevated baseline APTT. Now, this is also seen in the same as factor 12 deficiency, but here it is not get corrected by the addition of normal plasma, which differentiated Epla from the factor 12 deficiency. And again, arterial thrombosis are seen in this condition, which is not seen in factor 12 deficiency. There may be another manifestation like livedo reticularis, low platelet count, renal disease, or thrombosis formation on the cardiac valves similarly, right? Now, important portion is diagnostic criteria. It has to have laboratory criteria plus clinical criteria, which may be either thrombosis or it may be pregnancy-related morbidities, right? Now, discussing about laboratory criteria, first is lupus anticoagulant testing. When we are sending the lupus anticoagulant test, we must understand its interference. So, confirmation of lupus anticoagulant requires 4 criteria must be met. So, first is prolongation of at least one phospholipid dependent clotting test, right? So, commonly what we are doing is in our labs is APTT as well as DRVVT. These two are commonly done. So, ideally, 2 different assays has to be done simultaneously. So both should have been prolonged. Then it should not be corrected by mixing patient's plasma, right? Suggestive of presence of inhibitor. So both should be prolonged, not corrected by mixing patient plasma. Now you add phospholipid into the same mixture, it gets corrected, which suggests a phospholipid dependency. And lastly, there should be exclusion of any specific factor inhibitor or presence of any anticoagulant drugs. right? So all four criteria present, then the lupus anticoagulant is considered positive. If any of them is not met, then it is considered as indeterminate. So in indeterminate cases, it is most important to identify the pre-test likelihood or the patient selection. So those with the low-grade likelihood, indeterminate cases are considered to be the negative, while those high-grade chances of getting positivity, even if they get indeterminate, they should be considered as being positive and should be observed or treated in the same way. There are obviously false negatives and false positives. So when you have acute thrombotic event, it may come out to be false negative. And acute phase response when elevated factor 8, again, it may come out to be false negative. On the contrary, presence of anticoagulant and specific inhibitor, as mentioned above, can result in the false positive test. Those who are on the warfarin for the long time, at least they have gap of 1 to 2 weeks for testing, and INR should have normalized to less than 1.5. Right? So this becomes very difficult during when you have suspected someone on the EPLA, you have started on warfarin, and then again you want to check the lupus anticoagulant testing. It is very difficult to interpret the results because you cannot take the patient off the warfarin. The next tests which are involved is anticardiolipins and beta-2 glycoprotein 1 antibody test. So these antibodies are detected by ELISA. Beta-2 glycoprotein 1 antibody assay are considered to be more specific, but to increase the sensitivity, guidelines recommend testing for both, right? So specificity is more with the beta-2 GP, but sensitivity is more with the anticardiolipin. Current guidelines include only medium and high levels of antibodies as diagnostic criteria to improve the specificity. Positive test results should be repeated after an interval of at least 12 weeks because transient APS can also occur in relation to the infections or drugs. Now, false positive test, high level of rheumatoid factors and cryoglobulins can also give false positive for this testing. The second acquired cause, malignancy. It is the second most common cause, around 10 to 20% of spontaneous DVT. Mucin secreting adenocarcinomas, particularly GI, GU, and hepatobiliary carcinomas, brain tumors, APMLs, and myeloproliferative disorders are common culprits. Abnormal coagulation parameters are common, but frank DIC is usually uncommon. VT is common, arterial are less common. Many times cancer may be the occult and undetectable at the time of DVT and may manifest after few months. Now, JAK2 mutation, just briefly, it is seen commonly in the MPNs. Presence of the JAK mutation in a patient presented with thrombosis indicates the need for workup of the MPN. For MPN patients, along with the JAK2, high WBC count is also an independent risk factor for thrombosis, right? Similarly, PNH, we all know the hemolysis is common, but patient can present with the thrombosis, both venous as well as arterial, and without any evidence of hemolysis. Mechanism still not known, but probably activation of the complement resulting in the endothelial damage. Now, PNH testing is done by flow cytometry on WBCs. So even if you do the PCV transfusion, it will not have any effect on the PNH results. This is just to summarize the prevalence of various thrombophilias. Now, this factor 5 laden and prothrombin gene, which is very rare in Indians. So for Indian people, we probably cannot need to go for this. Now, protein CNS already mentioned. What I want to show you here, 2 points, which is the risk of an initial VTE, as you can see around 10 times higher in these cases. But when you go to the pregnancy and this initial VT, chances of this VTE, it increases to as high as 15 times in the EPLA syndrome, right? So how to approach a patient presented with a thrombosis? First, clinical history. So you find out the site of thrombosis, whether there is any other complaint is there or not, previous bleeding or thrombotic event is there or not, right? Previous thrombotic event make him more susceptible. Family history of thrombosis, again, you have to take it. Other medical disorders, liver disorder, autoimmune disorder, cardiovascular disease, right? Pregnancy, any pregnancy related complications are there or not. Infertility also important in case of the female. History of any medications, not only anticoagulant, anticonvulsant, OC pills, HRTs, or even herbal medications you need to take in consideration. Next comes to the physical examination. You have to watch for skin rashes or anything for autoimmune disorders, icterus, pallor like liver disease or even hemolysis in case of PNH, air entries in case of lung lesions, cardiac murmurs, particularly for suspecting non-bacterial thrombotic endocarditis, peripheral pulsation when arterial thrombosis is considered, presence of bleeding in case of DIC or something, spleen, liver for hematological malignancies, presence of fasciitis suggestive of malignancy. Then CNS examination should also be considered in case of the CNS thrombosis. Basic investigation which we should do in all the patients. CBC for seeing abnormal cells or a low platelet, high platelet, essential thrombocythemia and MPN features. Peripheral smear for the same as well as seeing for the abnormal blast cells. PT, APTT. If prolonged, you also do the correction study. LFT, RFT, and proteins. Protein is particularly important to identify whether the patient has having any protein losing disease. Chest X-ray, sonography of the abdomen, lower limb venous Doppler, site-specific testing and imaging. 2D echo is also an important test which should be done in most of the patients presenting with thrombosis. AN and TSH that we are doing commonly, but their role is controversial, and if there is a clinical indication, we should do that. So when to suspect thrombophilia? Any VTE occurring at young age, strong family history, recurrent VTE, spontaneous VTE and unusual psych like cerebral or splenic veins, recurrence pregnancy loss, asymptomatic patient with prolonged PT, APTT. We should suspect the presence of thrombophilia. So how to do laboratory testing for this? So there is no single laboratory test which is adequate. You have to find out most informative tests which may differ depending on the location as well as type of the thrombosis. A testing algorithm should provide maximum diagnostic potential and prevent unnecessary expensive testing, right? And it should be a stepwise manner. Like if you do here, this is a screening test, then you should do the confirmatory test, which ultimately gives the diagnosis. Like you initially do PT, APTT or anticardiolipin antibody assay, which are sensitive screening tests. Then you go for the confirmatory test, beta-2-GP1 and lupus anticoagulant testing to find out Epler syndrome. For protein C, S, and antithrombin, first is functional assay. If they are abnormal, go for the antigenic assay. CRP, factor 8, fibrinogen should also be done in other cases. Now, activated protein C resistant assay should be the basic screening test. And then if positive, we may go for this. Role of homocysteine and MTHFR is controversial, so we can avoid that. Now, factors which can influence the test result. This we need to keep in mind when we are ordering a test. Hypoproteinemia due to protein loss, surgery, trauma, burns, hemodialysis and renal dysfunction, liver disease, DIC, pregnancy, drugs, acute thrombosis, any active infection, and even active inflammatory disease. All these factors can affect the test results. So you can see here, if you want to do the hereditary thrombophilia profiling, and these are the various major thrombophilias, antithrombin, protein C, antigen and activity, protein S, factor 5, and prothrombin. So if there is an acute thrombosis, you can't do anything. Pregnancy, usually you can't do anything except for this PCR-based method, which can be done at any point of time. Unfractionated or low molecular weight heparin, antithrombin cannot be tested. Protein C and S still can be tested. Warfarin, most of the tests cannot be done. DOX, some can be done, some cannot be done. Right? So you have to keep in mind when you are ordering the any test, whether the patient is taking any medicines or not. Now, will it change the management is first important criteria. You should ask this question. So often the answer is no. Contrary to the popular belief, thrombophilias have either modest or no association with the risk of recurrence. Several proposed prediction models out there for recurrence, but none of them includes the thrombophilia status. So in most cases, testing will not change choice or duration of anticoagulant. In case of unprovoked VTE, there is always a high risk of recurrence regardless of thrombophilia status. So risk is as high as 50% for 10 years. And if it is provoked VTE, then whether the thrombophilia is there or not, the risk of recurrence is very low. If the inciting factor persists like malignancy, you have to continue anticoagulant despite the presence or absence of thrombophilia. And anticoagulant failure rate, that is if the patient is on anticoagulant and still develop VT, there is no difference regardless of thrombophilia status. So you have to remember the pitfalls of the testing. The best time to test is remote from acute VT, at least 3 months. Patient should be off all anticoagulant, not on any estrogen containing medications or pregnancy, should be free of acute infections and active inflammations. So in ideal cases, the hospital is not probably the place to test, except certain DNA and RNA tests. The tests are easy to order, but very difficult to interpret. Mostly they do not change the management. It can lead to anxiety if positive and false sense of security if they come out to be negative. Often requires repeat testing, discomfort and expense increases. This is a British Journal guideline which has been there for how or when you should test for hereditary thrombophilias. So if it is first DVT, provoked, no testing, unprovoked or upper limb, it should not be generalized. Everyone should be tested. Only few subset who are considered high risk, they should be tested. If it is catheter related, no testing. Retinal vein obstruction, no testing. Cerebral vein or splanchnic vein, you can test, but it does not help to predict the recurrence and thereby management. Now, what to be done for pregnancy? If a pregnant woman had a family history of venous thrombosis, if the lady has other high risk factors like smoking or obesity, then you already have to start her on thromboprophylaxis and there is no need of testing. If she does not have any high risk factor and the event in the family was unprovoked or related to the pregnancy, then the testing should be done in that lady. Similarly, if the lady has a history of thrombosis, so in this pregnancy and she had a previous history of thrombosis, if it was due to major provocative factor, then no testing or treatment is required. If it was unprovoked, then you do not need testing, just start thromboprophylaxis. Only when the provocative factor was minor or questionable, then you should do the testing, which can help to decide the thromboprophylaxis need. I mean, if a patient is found to be positive, now whether his family member should be asymptomatic family member should be tested or not. So if the mutation is low risk, like factor 5 Leiden or prothrombin gene mutation or other rare mutations, then there is no point in testing. And if other high risk like antithrombin or protein CS deficiency, then still it should be discussed with the individual. And if the individual is understanding the risk, then it should be tested. For arterial thrombosis, no point in testing for hereditary thrombophilias because they all are venous. Similar for children with stroke, heritable thrombophilia is not indicated. If patient develops skin rashes while starting on warfarin treatment, you should do the protein C testing, but it should be after 1 to 2 weeks. And neonatal purpura fulminans, in this case, you have to do urgent protein C and S testing because this can lead to the DIC for the patient. One more few occasions where you can help with the testing is when you are considering optimal OC pills in a female with either family thrombophilia or who has an history or VT while on OC pills previously, or having smoking or obesity like high risk. Why it is helpful? Because different OC pills have different profile, like second generation are better in case of thrombosis. Estrogen dose, if it is higher, there is higher risk of thrombosis. So best option in this case is progesterone only pills, Mirena IUD or copper IUDs, right? So here it will be useful to identify if thrombophilia is there, you switch over to this. If no thrombophilia, you can go with the other drug. Infertility, any female with history of recurrent miscarriage may benefit from testing, may change management strategy, LMWH plus or minus low dose aspirin, right? Like EPLA. Now coming to the last portion, management principles. So for management of DVT and PE, this was from the ASH 2021. Home-based treatment, unless there is any complication that require hospitalization. DOACs are now preferred for all DVTs and PEs, except creatinine clearance less than 30, liver disease or EPLA syndrome. All DOACs are equal in efficacious and safety at present. Thrombolysis should be considered for 1. Young patient who has a proximal limb DVT and that can lead to the limb threatening. So in this case, you should do thrombolysis. For a patient with massive PE and hemodynamic compromise, you should do thrombolysis. Ideally, it should be the IV thrombolysis. If it is contraindicated or there is some reason for IV, then you can go with the mechanical thrombectomy. For PE with RV dysfunction, but again, no hemodynamic compromise, then you can just go with the thrombolysis. Only because it is correct. You can even only go with the DOX, and thrombolysis is considered to be very high risk for bleeding and should be avoided. IVC filters should be avoided in patients with pre-existing cardiopulmonary disorders. So this is management of the DVT, initial management of 5 to 21 days where you give the LMWH or the DOX. Then there would be a time duration for primary treatment. And then there would be a time point from where you have to start the secondary prevention. So if it is a transient risk factor which can be eliminated, then this is good enough. You stop here treatment. But if it is unprovoked or chronic risk factor like malignancy, then there is no stoppage. This will continue for indefinite period. Anticoagulant. Secondary prevention, aspirin should not replace anticoagulant. For patient who is on aspirin and need anticoagulants, so if the patient's cardiovascular disease is stable, you can stop aspirin and switch over to anticoagulant. But if patient has recent MI or coronary procedure done in last 3 months or something like that, then you cannot stop aspirin also. You have to continue both, but there is always a high risk of bleeding. For secondary prophylaxis, if you are using warfarin, keep INR between 2 to 3. And if you are using DOX, keep a normal or even low dose can be used, like 10 milligram of rivaroxaban is good enough. Now, duration of secondary treatment, which is very important, should not be decided by testing of D-dimer, prognostication of recurrence, like prognostic scores, or use of Doppler. If it is recanalized, can we stop? Or hereditary testing, right? So none of these factors should determine the duration. The duration is basically determined by the inciting event, the primary event which has led to the DVT. If it is provoked, you can stop. If it is unprovoked, you can't stop. If a patient develops a new DVT or PE while on adequate secondary prophylaxis, treat with LMWH for recurrent DVT and PE. Management for cerebral vein thrombosis, anticoagulants is always started early. LMWH is usually preferred only except the cases where there is operative procedure is expected, because unfractionated heparin can be stopped and action can be immediately reversed. Mechanical thrombectomy should be done only if there is a contraindication to heparin. However, you should keep in mind that presence of hemorrhage associated with CVST, like in area of the venous infarct, is not a contraindication for the heparin, and heparin should be given in these cases. IV thrombolytics may be required if no improvement after anticoagulants or in case of extensive CVST. Surgical decompression should be considered if there is an herniation chances. IV thrombolysis should be combined with mechanical thrombectomy if possible. Lifelong anticoagulant should be considered. Data on NOACs is encouraging, but still we need some long-term trials. Management of abdominal vein thrombosis. Now, MPNs and PNH must be considered when you are getting the abdominal vein, arterial or venous thrombosis both. Detection of heritable thrombophilia should not alter the management as mentioned earlier. In acute now portal vein thrombosis and patient is not having cirrhosis, then anticoagulation should be done. But if patient is already having cirrhosis, then there is a risk of bleeding and we have to individualize depending on the patient's condition. Acute hepatic vein thrombosis, it again give the anticoagulation, LMWH is preferred, but if required, you even need to go for the TIPSS. Patient with acute mesenteric vein thrombosis without peritonitis, again conservatively manage anticoagulant, but if it is peritonitis, you might need to open and surgically decompress. Duration of anticoagulation is not defined, but when possible and unprovoked, consider for long term. Role of anticoagulants in chronic thrombosis is questionable and should be individualized. Lastly, one slide of management of APLA syndrome. I am not covering in detail because we will have a session on APLA in the future. More appetite for long-term, you have to go for the long-term anticoagulant with true APS because of the high risk of recurrence, particularly in a triple positive cases. That is lupus anticoagulant positive, anticardiolipin is positive, and anti-beta-2-glycoprotein is also positive. APS will cause APTT prolongation like lupus anticoagulant, so it can cause difficulty with heparin infusion and management of its dose. So unfractionated heparin is more useful. if you're doing unfractionated heparin, then you should do the anti-factor 10 level. And alternatively, you can use the low molecular weight heparin. If you have obstetric KPS, antepartum, postpartum, prophylactic LMWH along with aspirin, livedo or thrombocytopenia without thrombosis, you do not have any evidence to suggest you should go for treatment. And again, there is no evidence to support corticosteroid or other immunosuppressives except for the catastrophic APLA syndrome. So last slide's take-home message is hypercoagulability can result from a variety of inherited and more commonly acquired conditions. Thorough clinical history is very important to rule out acquired causes. Plethora of tests are available in the name of thrombophilia profile, but clinician needs to be judicious for their use. Pre-test probability of getting positive results and its effect on patients' management needs to be discussed and clarified. Do not hurry in ordering tests. Most of the tests cannot be done during acute thrombosis or while on anticoagulant. Use of an algorithmic approach is more important. Interpretation of these test results is tricky and need guidance from expert pathologists also. Positive thrombophilia test does not alter initial treatment, treatment intensity, or even duration of anticoagulants. DOACs have significantly changed the management of DVT and PE, but their role in thrombosis of other vein is still premature. Thank you.